We want to thank our partner, AvaSure. Over 1,100 hospitals are using AvaSure's virtual care platform to engage with patients, optimize staffing, and seamlessly blend remote and in-person treatment at scale. Drive measurable outcomes and augment clinicians with an AI-powered solution that deeply integrates into your clinical workflows. AvaSure offers virtual care solutions supported by a secure, scalable infrastructure that helps you to lead your organization into a future where cutting-edge technology and compassionate care converge. For more information, check them out at thisweekhealth.com/AvaSure. I'm Bill Russell, creator of This Week Health, where our mission is to transform healthcare one connection at a time. Welcome to Newsday, breaking down the health IT headlines that matter most. Let's jump into the news.
Well, Jacob, thank you for joining us for Newsday. We're always grateful for your partnership and being able to spend time with you.
Pleasure to be here.
So you get Drex and myself today, but Jacob, just in case anyone is not as familiar with you and your organization, would love for you to share a little bit about you and AvaSure.
Happy to share. My name's Jacob Hansen. I'm the Chief Product and Technology Officer at AvaSure. Been with our business coming up on 3 years. AvaSure is a virtual care platform focused on, in many cases, inpatient acute environments, but also admitted patients at home. We're starting to move into broader continuums of care. We're a hybrid, physical endpoints that allow us to interact with patients, and then also software. And we focus on virtual observation, virtual visits, artificial intelligence, all of those things.
Which is such a perfect foray into one of the first things we do want to talk about, and that was recently from Becker's, that CEOs are putting a little bit pressure on CIOs for the strategic value of EHR AI. And a couple of things that came to mind for me, and I'm so glad you shared this one, is that the whole demonstration of real business value before approving large-scale EHR AI projects, it's still alignment within the organization, strategy and workflow. There's the built-in financial models and sustainability, but also digital maturity that we are seeing. I'm curious for you, when you're meeting with your clients and some of the things that you're hearing in this space as well.
It's been interesting to observe maybe the cultural dynamics or the governance that exists system by system that they use for evaluating how they introduce new technology. Certainly, we've gotten a lot of feedback from our customers about the overwhelming, or maybe a better word would be like a deluge of pilots that happened for several years with all of this new technology, especially with artificial intelligence. And we started to see a lot more CFOs lean into an expectation of hard return, which I think is great. And so we're excited about that. I think one of the reasons that we're interested in seeing headlines like this is we're very much a clinically minded business. We have a lot of employees who are clinicians. So in the back half of 2025, we're actually partnering with health systems on doing clinical study to generate some evidence that other health systems can benchmark against. What exactly should we expect for augmentation of a virtual safety attendant? Or how much more can we achieve operationally in a nursing unit based on different models that are being deployed? And so we're excited to see this take shape, and hopefully we can really lean in and be a part of the change. I think it will make the whole industry better, all of us. Health tech partners and health systems themselves, I think, will be doing a better job of managing cost and being smarter about what we deploy and just how much we foist upon bedside care team members at the same time.
It's really interesting. Sarah and I were talking earlier today. This is a lot of stuff that happens. Sarah and I will wind up talking about some of these things that boomerang back around into other conversations that we have. We were talking earlier today about like CFOs and other fellow execs can be very reasonable people when you provide them with actual facts about what it is that you're doing, as opposed to making emotional arguments about why we should actually invest in this. It's good for us. It's good for the nurses. But good isn't really like a solid metric to help pull these things across the line. So I love the idea that you're going to do some studies with some health systems, set some benchmarks to kind of say, how do you compare without AvaSure? How do you compare on this and this? Mm-hmm. So you can see where you are and compare yourself then to customers and the work that they're doing and the investments that they've made, but the improvements that they've received, the safety improvements, the dollar value, like you've got real numbers to be able to help build these business cases. And we're just in this environment right now with the big, beautiful bill and the drawdown possibly of Medicaid, a lot of the Medicaid dollars, the pressure that a lot of health systems are under, especially rural health systems. And we're going to talk about that. They have to have good business cases now. They're not just doing things on emotion anymore.
I think the great news is that the benefits of measuring these things go multiple directions. The better data that we have, the better clinical evidence that we have, the more bedside clinicians will trust what the technology is doing to augment their work, while also convincing executives who have to think through the cost of licensing these tools, right? They get the benefit of the data in justifying their decisions. So you've got both users and buying personalities who get benefit. And it does mean we have to be ready to invest. If we believe what we believe about the power of AI to fundamentally change or support this transition to alternative care models with virtual and bedside participation, we've got to be willing to invest in some of these studies up front to help demonstrate what's possible.
As the product guy, this information also comes back to you and helps you focus on the things that make the most difference too, right?
Yeah, I mean, the only way we're going to get clear, iterative feedback from those that are most affected by the use of the technology is by doing these things. And on the product front, our whole team is very excited about going beyond, sometimes a pilot can turn into, here's the thing, and we're doing it at no cost or low cost, which is what the industry expects. And so you want to turn it on and sort of let it sit, but we have to be an active, engaged party to what's happening there.
I'm going to have you guys toss your financial hats on because obviously, Jacob, you're doing deals all the time. I like to think of Drex as like the CFO whisperer. He always has like a way to get to like the value management office or others. And that's the whole structure of a cost model that has like a contingent fee arrangement. Does it lower adoption barriers? And how does it pave a path for innovation and also taking on some of that financial risk?
Yeah, it's interesting. The thing that we're interested to monitor over time will be what remains a primary or a hard return metric versus those that are often thought of as adjacent or soft or secondary return measures. We're going to be excited to try and support the industry in demonstrating that some of these things are actually measurable as hard dollar return things. Like impact of AI to, and look, we could get more specific on what types of AI we're talking about. AI means a million things, but let's say that we took computer vision focusing on turnover in a room or monitoring a patient's readiness for discharge. What's the impact of that on length of stay? Well, there are many things that influence length of stay, and there's never just one program or priority aimed at changing that. But how do we come up with clear evidence as part of these studies to really demonstrate this one change that you're making is influencing this key measure, and here's why and how.
Yeah, by this much, right? And the beautiful thing about that too is that when you build those kind of calculators and they're not black boxes, you can also let the executive or the clinician tinker around with that knob a little bit. They can set it where they think it's right for them, which makes it even more convincing because now it really becomes their data and their decision about what to do. You said something else earlier that I think probably bears some additional quick conversation, but the idea that we go into a lot of places and we do pilots and we do pilot. It's almost like they will say yes to a pilot just to get to, I don't want to talk about it anymore. Yeah, let's just do a pilot, but they don't actively engage in the pilot. They don't really aggressively like put themselves into it. And that can be a huge waste of time for you. And it can be a huge waste of time for staff. And ultimately you kind of get a black eye on these things. So how do you guys, when you do pilots, how do you think about what do I need from the health system? Like what's the agreement to build a pilot and do a pilot and feel like you do it right? A proof of value, whatever you want to call it.
The key for us is in what way are we both planning to lean in? Pilots, especially around AI, if they don't involve some clinical change management and expectation for what's different for those that are at the bedside or virtual care team members that are participating in patient care, then the pilot's not going to produce a healthy outcome anyway. So our expectation, I would say it's different depending on the models that we're deploying, but we really want partnership. Not this thing's going to be running and we'll look at it again at the end of the pilot, but meaningful monitoring of change. And with that, you made a point about what we're measuring. Yeah, we have to be clear up front. What do we expect this to do? What's our hypothesis? How do we track it over time? And we have team members in our product organization and then also in customer success who are, have clinical backgrounds, who are participating in these programs, these pilots or clinical studies, who will be a part of it throughout the process, who are setting those expectations so that at the end that we have an outcome where we can quantitatively and unemotionally look at the data. And I think that's another point you made that I really liked, which is the intent of a pilot is not to game the measures, right? Any good statistician can tell whatever story they want with numbers. The goal here is not to do that. It's to look at what really happened. And if that means we're going to tweak some things or make adjustments, fine. But otherwise, no, we got to look at really what occurred and how are we going to go forward.
Yeah, we're going to do this POV. We're going to do it for X number of days. Again, Sarah and I have talked about this. We're starting here. And if 90 days we can get it to here, then I think part of my obligation as the CIO is to say, if you can get it from here to here, I'm telling you, I'm really interested in having a conversation about how to close this deal, right? You've got to have that kind of commitment to really make sure that you're going to be able to get across the finish line and have the great effect that you want to have for patients and families.
Agreed.
Which is such a great perspective, truly, when you think about adoption, impact, governance, the phased approaches. It's exactly what they're doing at Common Spirit. 230 tools with $100 million impact. One of my favorite things about this article that Jacob shared with us is that they only had like 130 of them or 100 of them previously. So they moved a massive amount into this space, but it's been both AI and RPA implementation. But one of my favorite things, their governance structure, they call EDAG. Ethics, Data, Algorithm, and Governance Committee. But the reason they did that, it's diverse clinical, compliance, ethical experts. Every 2 weeks, they're meeting to evaluate new tools. And so, Jacob, a question I have for you in that whole space is that they began with back office, then went to employee and patient engagement. Now they're looking in clinical workflows as an example. So that whole in-the-loop conversation where you've got the ethics experts as part of this and the clinical buy-in, how does that impact some of the work that you're doing so that those things are being talked about as part of your product suite?
It's a big difference for us as a technology partner because it gives us guidance or guardrails on how we work with their existing process. We've had AI offerings in our platform for a couple of years now, and it's already making a big difference that health systems are starting to establish governance programs like this one, maybe not quite with this much detail or maturity around them, but it really helps us make sure that we're not introducing things that the rest of the organization is not ready to accept or to participate in. And it kind of goes back to the point you were making, Drex, about how we're empowering the people in an experiment. Because if we're experimenting with something in one building, in one unit, that's disconnected and redundant to something in another part of the health system, that's not productive. What's going to protect against that? Governance programs like these. The other thing is, it's also good for us to see this because it helps make sure that we are making sure that we're delivering on the same behavior, the same culture. So at AvaSure, we saw the need and are standing up our own AI Center of Excellence. And we will be using that mechanism to evaluate what new AI tools or opportunities we have inside of our own operations, how we make sure that we're delivering on ethical use of those tools, that we're engaging all of our team members in them, that our culture builds around those things, so that we're thinking about the AI we use in the building in the same way that we're wanting our customers to use it in practice within the health system.
So Jacob, if you think about part of their approach, which is like starting with lower risk areas and gradually expanding into more complex use cases, how does that best fit into the way that you roll out your product? Because if you've got that constant clinician oversight, you're also building that muscle into the organization. It's part of their DNA, really, about how you think about utilizing the product in a way that both, to your point, the adoption, the change, all these pieces. How does that framework apply? And where do people start with you? What's the best first use case when spending time with you?
You know, what's funny is this conversation about layering outcomes and use cases, it actually ties right back to the first topic of return on investment, because you're going to have a lot more runway and a lot more opportunity to deploy new technologies if you start with the things that have the best ROI first. So if you take something, and this actually involves pilots of more traditional technology, even before artificial intelligence, if I do an implementation of a centralized hub and spoke driven virtual sitting program dedicated to falls, elopement, and behavioral health, and I'm monitoring those, and I set a benchmark at a 1 to 12 safety attendant to patient ratio, and then I layer on falls and elopement, and I start with specifically falls, and I'm looking at the impact on what number of patients I can monitor. And I'm doing clinical study that says, I could, at 10 p.m. with only falls patients, I can actually go with clinical evidence from 12 to 25, and I can feel really confident in that. Well, what happens now if I add an elopement model that looks at what happens when I'm monitoring behavioral health patients and risks at 2 p.m. when they're agitated and lots of motion happening? Okay, now we've got the endpoints there. We're already getting an ROI, even at 1 to 12. We're expanding on that with improved ratios. And now I'm going to add a patient mobility model that focuses on prep for discharge. And then I'm going to add nutrition delivery for diabetic patients. All of that, each one of those should have value on their own, but it's got to be built on the backs of something that creates a return by itself out of the gates. That's how you make the case to keep growing innovative things like this over time.
Drex, that's your Maslow right into one like product.
Yeah, I'm sitting here. So my mind is sort of split between, I feel a little bit like we're playing SimCity, which is like there are things you have to start with in the beginning to be able to build out your SimCity. So from a gamer perspective, if anybody can relate to that, maybe we start there. But the other one is I grew up as a farm kid, and there was a lot of decisions that we made early on over a number of years about we're going to grow wheat because wheat is a really low risk crop and it's going to grow, and like we don't have to worry that much about the rain. It's got to rain, of course. And then we moved. So some of the fields then started to move in again. Once we had good movement and we felt comfortable from a business perspective, things were running okay, then we could take more risk on crops that might fail, on particular kinds of crops that might fail, but had a much higher payoff. But we couldn't start with those. We had to start with the things that we knew we could rely on. And so I think this layering on ROI on top of ROI, go do the hard stuff, do the easy stuff first, the stuff that you know you're really going to be able to rake in the ROI, take a little bit more risk over time. I love that approach. I think that makes great sense to me.
Sometime when we have a little more time, Drex, we'll have to swap some farming stories. My dad grew up on a farm in southern Idaho, and I've got a great story about a time that he dropped wheat on 3/4 of a mile of roadway that in the end he had to sweep up. So, a story for another time.
No story for another time.
Like, how long did that take?
A long time, and he gets teased pretty intensely about it by his siblings every year. So, it's pretty cool.
Well, then it gives me a sense of why I know why you have such a passion for rural healthcare, not only because it's the right thing to do, but obviously maybe some of that literal DNA being mixed in there. But one of the things I love is the last article that you shared is about the ability to tailor some of these solutions for the community hospitals. They struggle with implementing something that's really been designed for large enterprise workflows. And they have to be creative in getting the workflow and the data and limited staff and visibility all aligned to be able to make these things happen. Obviously, super users being an option there. But when you have internal expertise, the clinical administrative task force, et cetera, that can bridge some of those gaps, then even potentially using a third party or a partner like yourself who can find better outcomes and improve user satisfaction. With everything happening, funding and access and whatnot, you've always leaned in to the rural and community facilities. How do you adapt these big solutions or big system solutions into their environments?
Definitely one of the reasons that I liked that last article so much. Our three primary value propositions at AvaSure are workforce productivity, patient and caregiver safety, and then the third is reach, caregiver reach. And we have the benefit of having been involved in virtual care for a lot of years now, 16 years. And so we've got a footprint in over 1,200 hospitals. In many of those cases, those are smaller, either independent or small health systems with rural hospitals involved. And so one of the reasons this article caught my eye, I know it was about EHR, but it was talking about a rural hospital that had a solution, and they had been thinking about other technologies and options, and they decided to optimize what they had in order to decrease manual work and administrative work. That is exactly what we want to achieve with our customer partners, health system partners who have these rural hospitals. Take a platform that you're already using. No need for major overhauls or migrations. We have lots of new tools. Many of these smaller hospitals might not have had the opportunity to deploy the newest things that a virtual care partner has to bring to the table. We want to lean in and help these smaller hospitals take full advantage of deploying those things. And that means bringing all of the same clinical change programs, all of the same analytics, the same expectations, but to be able to do it at a smaller scale without needing a massive migration, full changes to every room. You've got to have a far more, we call them bridges. You've got to have bridge strategies to go from where they are to where they want to be, and to be able to do that in a different way than, say, a large multi-state IDN would do it.
Is it fair to say that virtual care should be considered infrastructure and not an add-on to these other pieces, that it's actually required to be able to have like lack of fragmentation of virtual visits, integrated team-based models, the seamless coordination, heck, on-site, remote, hybrid provider roles? I mean, if we make virtual care part of infrastructure, part of the must-haves in an organization, does that resonate for people? And if they start thinking about it that way, where does that live? Because it's not going to necessarily just go to the CTO per se.
Look, there's another thing here that I think just drives me a little crazy. It's not drives me crazy. It's just, we've been talking about this for a long time. I'm a huge fan of telemedicine. I'm a huge fan of remote care. I think maybe another way of saying what you said, Sarah, is that we should just call remote care and telemedicine. We just should call that healthcare. This is what it is. It's not, yes, there's technology involved, but there's technology involved in everything that we do today. So this is just care. It's just a different way. We got to figure out the reimbursement mechanisms and all the stuff that kind of causes it to have a hard time, that are sort of like structural roadblocks to care, good care. But this is good care. And in this environment, especially in rural, where they don't have the number of healthcare professionals they need. They have an aging workforce. And so the doctors in rural areas are older than in urban areas. They have recruitment and retention challenges that the rest of healthcare doesn't have. This model is built for places that need this kind of help.
It's a great point. It certainly probably would be convenient as a health tech vendor who focuses on virtual care to say, oh, this has to be infrastructure. Wouldn't that be great? However, if I were to think about this just from the perspective of our customers, a couple of things that stand out to me. First is that when you even just look at the quality of the outcomes, we could take something simple, right? What was the first thing that everybody wanted to do in virtual nursing when virtual nursing just became all the rage and people were wanting to pilot that. It was discharge. Well, there's now plenty of data that demonstrates that in many cases, a virtual discharge can drive up patient satisfaction, can reduce the time the discharge takes to deliver, and can drive down readmissions because these people have more time to spend without having to run from room to room, without having to be distracted from the other 20 things on their plates that they have to do. Their job that day is to do virtual discharge. And that kind of attention delivers on the outcomes. The second thing that you made me think of is, okay, yes to it being part of infrastructure, but what must be true? What does every health system say to our business as we're talking about relationships with them or building our relationship that we already have? I can't have more than one endpoint that does the same thing. Whatever I put in my room, it's got to be able to do multiple things. So yes to it being part of infrastructure, but that thing better have the capability to let third parties participate by using that endpoint as their own. That's the reason for things like the API that we've invested in. And then not only that, but if it's going to be the endpoint that allows many things to come and participate, it has to have proven value, it has to support experimentation, and it's got to arbitrate all the access. It's got to decide who gets to participate in bedside care from a virtual position and when and why, with some rules and guidance. This is what we're so excited to measure. And actually, I'll just put a plug in, very selfish plug. We got our big AvaSure customer symposium coming up in 2 weeks, my favorite event of the year. And one of our customers is coming to present on the use of our AvaSure episodic application in rural settings and the efficacy and benefits of doing that. So I think the market can speak for itself on exactly why, to your point, Drex, virtual care is healthcare.
Jacob, I have one last question for you. And this comes from your own survey, and that is that adoption remains nascent, even as the executive sentiment shifts are strongly positive, obviously. But the gap carries opportunity and risk that for systems that wait. So HIT leaders, they need maturity models, metrics, frameworks, governance that moves them from pilots to predictable performance. How are you structuring that conversation, knowing that it's a matter of just leaning in and going for it? But if they need help with a maturity model, a framework, governance to do all these things, what are you seeing?
We're just trying to make sure it's clear we are willing to lean in on demonstration of ROI to drive prioritization of IT resources. Every pilot comes, even if it's a free pilot in terms of license or cost in the solution, there is an IT and clinical labor cost. It's unavoidable.
Yep.
So we've got to just be consistent in saying, here's what we can bring to the table. Here's how we'll help you manage the IT and clinical costs to support these new things that you're deploying. And here's how fast you can expect a return so we can move from use case to use case as fast as possible. It's really the long and short of it.
Excellent. Drex, final thoughts.
No, I just like the idea of you're building it like my brain works in analogies. You're building it like an airport, and there's a lot of planes that could land on the runway, but you're trying to put them on the runway in the right order that makes the most sense, that does the most good for all the people, all the passengers on the ground, all the people in the airplane. So that approach of like layering on and helping them figure out what should come first and that should come later. I wonder sometimes too a little bit, not making investments for a long period of time almost gives you the opportunity, if you're a rural organization, to leapfrog into a position where you never would have been able to be. The delay almost works to your advantage. Do you see some of that too?
Yeah, I think so. I think letting other organizations cut their teeth on new technology a little bit allows second and third generations of those new things to come available when the time is right for a smaller health system. What you said reminded me of a phrase that we're always using in our business, which is we've got to let or help support health systems hit the easy button. When it's time for them to migrate to the newest, best applications or algorithms that we introduce, what can we do to make that process of going from, oh, I'm a health system that's been doing virtual sitting with mobile endpoints for years, and now I want to have fixed endpoints that allow me to do virtual sitting and add virtual visits plus virtual pharmacy. And I want to be running artificial intelligence for this, that, or the other thing, ambient listening for ambient clinical documentation through partners that we bring to the table. How do we just say, oh, here's the recommended migration path. Don't turn all that on at the same time. You're going to break the change process. Start here, then this, X, Y, then Z, and arming our customer success teams and professional services teams to guide our customers on that journey.
And what I have faith in is that your technology is far more current than our current ATC infrastructures. They'd still print things out and use little tiles to move them around in the tower. And you know that I'm being honest when I share that with you. It's like, grateful that's not exactly how we're providing patient care these days. Jacob, always such a pleasure to spend time with you. Thank you for bringing some really great ideas forward from the recent articles, but also thank you for everything you're doing to move patient care forward and the work you're doing with AvaSure.
Thank you for the time. It was great.
Yep, Drex.
Thank you. See ya.
Always fun to hang out. And for those of you listening, thanks for tuning in to Newsday. That's all for now.
That's Newsday. Stay informed between episodes with our daily insights email. And remember, every healthcare leader needs a community they can lean on and learn from. Subscribe at thisweekhealth.com/subscribe. Thanks for listening. That's all for now.